Imagine we decide to open a medical company in the United States. Our first product is not a drug. It is not a robot. It is not a new kind of surgical tool. It is a small vial containing roughly 250 living fly larvae. And if we do this correctly, a hospital may order that vial by prescription. That sounds like the easiest business in the world to misunderstand. We could look at the organism and think the product must be cheap. Flies reproduce. Larvae are tiny. How expensive could this possibly be? But the larvae are not really the difficult part. The difficult part is everything that has to happen before a hospital is willing to put our package into its clinical workflow. In the United States, medical maggots and medicinal leeches are regulated medical devices. At the end of 2024, the FDA moved regulatory responsibility for both categories from its Device Center to the Center for Biologics Evaluation and Research, specifically because these products are living organisms. So before we breed anything, we have already crossed an invisible line. We are not opening an insect farm that happens to sell to doctors. We're trying to become a medical device manufacturer whose inventory happens to be alive. And a live inventory creates a strange problem. A recent FDA summary for Medifly maggots describes a single-use product with about 250 Lucilia cuprina larvae, reared and disinfected in a controlled environment, placed in a vial that allows air exchange while limiting microbial contamination, and supported by a transport medium designed to keep them viable while slowing their development. The same FDA document says the product is manufactured on demand and dispensed on prescription. One established American supplier, Monarch Labs, says its medicinal maggots are produced weekly, prepared to order, and so perishable that they cannot be stored beyond 24 hours after arrival. So picture the business from our side. A hospital places an order. Somewhere inside our facility, a living production cycle has to line up with a prescription. Quality controls have to line up with a shipping cutoff. The package has to line up with an overnight courier, and the courier has to line up with a clinical schedule. If any one of those clocks slips, our product does not simply arrive late, it may arrive too late to be useful. That is the real business we are considering, not selling maggots, selling a living medical product that has to be controlled, documented, viable, and on time. So if we actually wanted to own this company, where would we begin? The obvious temptation is to start with the biology. We need flies. We need larvae. We need containers. We need somebody who knows how to keep the colony alive. But that is not the first gate. The first gate is regulatory. FDA currently lists medical maggots under product code NQK. Medicinal leeches sit under product code NRN. Both are unclassified devices. Both go through the 510K system, and both are now reviewed by CBER. That matters because the commercial question is no longer, can we raise the organism? It becomes, can we manufacture a legally marketable medical product around that organism? There is a useful example from June of 2026. FDA issued a 510K decision for Cuprina's Medifly maggots, finding the product substantially equivalent to its predicate device. That phrase matters. Substantially equivalent is the regulatory language here. We should not casually turn it into the word approved, because that would describe the pathway incorrectly. As owners, this sounds like a technical distinction until we realize what the distinction does to our startup plan. A fly can reproduce without a lawyer, a quality manager, or a regulatory submission. A prescription medical device cannot. And this is where the business starts to become more interesting than the organism. The FDA's current quality management system regulation became effective in February of 2026. The agency says it now uses an inspection process aligned with that regulation. For a device manufacturer subject to those rules, quality is not a nice internal habit. It is part of the regulated system the company has to maintain. We also have visible federal fees. For fiscal year 2026, the FDA lists an annual establishment registration fee of $11,423. A standard 510K user fee is $26,067, with a lower fee for a qualified small business. Those numbers are not our startup budget. They are almost the opposite. They are the part of the startup budget we can actually see. The harder costs are the people, the facility, the documentation, the validated processes, the quality system, the equipment, the biological production capacity, and the working capital required to keep all of it alive before demand becomes predictable. And there is another owner decision hiding inside that list. Do we build only enough capacity for the first few hospital accounts, or do we build ahead of demand? If we build too small, one surge in orders can make us unreliable at exactly the moment we are trying to establish trust. If we build too large, the empty capacity starts costing us before the market has proved it exists. That trade-off appears in ordinary manufacturing too, but living inventory makes it nastier. We cannot simply fill a warehouse during quiet weeks and turn that inventory into sales 6 months later. Capacity that is unused today may be capacity we can never recover economically. So, even before the first hospital calls us, the business forces us to choose between two uncomfortable risks: underbuild and risk service failure, overbuild and risk fixed cost failure. That is the first important owner lesson. A strange product does not automatically mean a simple company. In fact, the stranger and narrower the product, the more dangerous fixed infrastructure can become. Because we may have to build the system first and wait for the orders second. To make the owner problem concrete, assume a hypothetical first-year plan with $180,000 for facility build-out and production equipment, $85,000 for regulatory/quality system/legal setup beyond FDA user fees, $150,000 for 6 months of staffing runway, $45,000 for 6 months of rent/utilities/insurance/software, and $40,000 of working capital reserve for packaging, urgent freight, replacements, and other operating surprises. Add the verified FY 2026 standard 510K fee of $26,067 and establishment registration fee of $11,423. Every number except the FDA fees is an illustrative assumption, not a sourced industry cost. To see the shape of the entry problem, let us build one deliberately transparent model. We are not claiming this is what a real startup must spend. We are asking what happens if we give ourselves a modest laboratory build-out, a small equipment budget, some regulatory and quality support, 6 months of people and occupancy, and a buffer for the ugly things that happen before demand is smooth. With the assumptions in our model, the capital envelope reaches roughly $537,000 before the business has proved it can generate repeat hospital demand. That figure is not a fact about the industry. It is a warning about the sequence. We can spend serious money making ourselves capable before we have evidence that enough prescriptions will arrive. And the most dangerous line in that model is not the FDA fee. It is runway. A regulated biological operation cannot be switched off every time sales slow down and restarted like a social media ad campaign. The colony has to be maintained. The quality system has to remain functional. The people who understand the process have to exist. The facility has to stay ready. That means the capital problem is not simply how much does it cost to open the door. It is how long can we afford to keep the door open while a tiny clinical market learns to trust us? And now we run into the next question. What exactly are we building? If we imagine the facility as a normal warehouse, we would already be wrong. One of the clearest public descriptions comes from Cuprina's securities filings. The company says it manufactures Medifly in its own laboratory in Singapore. The operation includes an insectary area, where the life stages of the blowflies are maintained, and a microbiology area, where harvested eggs are disinfected and processed into the final product. Moat, a specialist larval therapy producer in the United Kingdom, describes a similarly controlled production chain for its own product: fly husbandry, egg collection, disinfection, incubation, dosing larvae into porous pouches, heat sealing, environmental monitoring, and daily quality control testing. We should be careful here. A British manufacturing license does not tell us what our American regulatory obligations are, and Cuprina's Singapore operation is not a blueprint we can copy into the United States. But both examples reveal the same operating truth. A medical maggot business is not a room full of fly cages. It is a controlled production system with a biological colony inside it. Think about what that means for us as owners. We need a reliable source of breeding stock or a controlled colony. We need to maintain the life cycle. We need a process for collecting the right biological material at the right stage. We need disinfection and handling procedures that match the specifications of our product. We need people who can recognize when a batch does not meet those specifications. We need records. We need calibrated equipment where calibration is required. We need a process for non-conforming product. We need a way to investigate complaints. We need to know what happens when something goes wrong before it leaves the building. Cuprina says its Medifly production is certified to ISO 13485, and its filing describes quality procedures covering production, delivery, supplier evaluation, equipment calibration, non-conformance, corrective and preventive action, record control, and internal audits. That list sounds corporate and boring, but it tells us where the moat may actually be. The fly itself is not proprietary in the way a patented molecule might be. Cuprina says its Medifly products had no patent protection and that the company relied primarily on manufacturing trade secrets and know-how around identification, collection, breeding, and optimized insectary conditions. That is a fascinating business structure. Our visible asset is alive and reproducible. Our invisible asset is the process that turns something reproducible into something a hospital can trust. So our competitive advantage may not be owning a rare organism at all. It may be knowing how to produce a consistent medical product from a common biological life cycle without losing control of quality, timing, or documentation. Now imagine a normal morning inside our company. We do not begin by asking how many units we can stamp out before lunch. We begin by asking what stage the colony is in, what orders are expected, what product can be released, what needs inspection, what documentation has to follow the batch, and what can be discarded if it does not meet the product specification. The biological cycle and the commercial cycle are connected, but they are not identical. The flies do not know whether a hospital has placed a purchase order. The hospital does not care that our colony had an inconvenient week. Our job as operator is to place a controlled process between those two realities. That is why a failed batch is not merely wasted larvae. It can mean wasted technician time, wasted packaging, wasted capacity, a missed shipping window, and a hospital order that now has to be moved, replaced, or refused. We do not have a reliable public failure rate benchmark, so we should not invent one. But the quality procedures described by real operators tell us that non-conforming product, corrective action, calibration, supplier evaluation, and record control are not theoretical concepts. They are part of the operating system. This also changes how we think about staffing. A cheap product can sometimes be manufactured with cheap labor if the process is forgiving. Our process is valuable precisely because it cannot be forgiving in the same way. Someone has to know what normal looks like. Someone has to know when the colony, environment, package, or records are not normal. Someone has to decide whether product can move forward. That kind of knowledge creates a subtle concentration risk inside the company. The more process knowledge lives in a few experienced people, the more one resignation can become an operational event. And that is why the absence of a patent does not mean the absence of a moat. A patent can protect a product on paper. A difficult process can protect a business in practice, but process protection has a cost. We have to keep performing it every day, and that creates another owner problem. Normal factories want inventory. Inventory smooths demand. If we make screws, gloves, or plastic trays, we can manufacture ahead, put boxes on a shelf, and wait for customers. Our product does not wait politely. It develops, it changes, it has a useful window, which means our warehouse behaves less like a warehouse and more like a clock. The FDA summary for MediFly is unusually useful because it lets us see the product from inside the package. The larvae are reared and disinfected in a controlled environment. They go into a vial designed to let air move while limiting microbial contamination. A minimally nutritious transport medium keeps them alive while also delaying their development until they reach the patient. That transport medium tells us something important. The company is not merely shipping the product, it is managing time inside the package. FDA says MediFly is manufactured on demand. Monarch's current ordering terms make the commercial implication even clearer. Its medicinal maggots are produced weekly, prepared to order, and highly perishable. The company says they cannot be stored beyond 24 hours after arrival. For our business, that changes almost every instinct we would bring from ordinary manufacturing. Producing far ahead of demand can create waste. Producing too late can miss the clinical schedule. Producing exactly to demand requires visibility into orders, and the more irregular the orders are, the harder it becomes to use our people and facility efficiently. Imagine a normal warehouse manager being told that finished inventory cannot simply sit until next month. Now add a prescription requirement. Monarch says its product cannot be released without a doctor's order or prescription and is intended for one-time use for one patient. So the sale is not just a quantity decision, it is connected to a specific clinical need. That means our demand can become lumpy in a way a consumer business is not. We are not trying to persuade millions of people to impulse buy a box of larvae. We need a relatively narrow clinical use case, a prescriber, a care team, a purchasing process, and a product that is ready when the case is ready. This gives us a different definition of inventory. Our inventory is not simply larvae in vials. Our inventory is production capacity synchronized with probable demand. If we keep too little capacity, we lose orders. If we keep too much capacity, fixed costs sit idle. And if we make the product at the wrong time, the inventory can lose value simply because biology kept moving. There is another subtle difference between our inventory and normal medical supplies. Ordinary inventory lets the manufacturer separate production from sales in time. We make a box today, the customer buys it next month. Our business partially collapses those two events together. Production planning becomes demand planning. Demand planning becomes logistics planning. Logistics planning becomes clinical scheduling. That makes forecasting disproportionately valuable. A recurring hospital account that gives us predictable order patterns may be worth more than the same annual revenue arriving randomly, because predictable demand helps us use the biological and human capacity more efficiently. So when we eventually think about pricing and customer contracts, the most valuable customer may not be the one who pays the highest price per vial. It may be the one whose ordering pattern lets our factory behave like a factory instead of an emergency room for its own inventory. This is where the courier enters the business model, because after we manage all of those clocks inside our own facility, we hand the package to somebody else. There is a line in an old FDA supporting document for Monarch that captures the entire logistics problem better than a spreadsheet could. The company reported that its most common complaint was late delivery by express couriers, not manufacturing failure, not a shortage of flies, late delivery. The filing explains why. Medicinal maggots are highly perishable, and because they have to arrive immediately before the patient's procedure or appointment, delays of even a few hours can cause significant inconvenience. That is historical evidence, but Monarch's current commercial terms show that the same underlying constraint remains real. The company uses a 1 p.m. Pacific order cutoff. It has specific rules for products that arrive late or non-viable. Depending on the timing and circumstances, late delivery can trigger replacement or credits. Now look at this from our side of the invoice. We can run the insectary correctly. We can disinfect and package correctly. We can document the batch correctly. We can ship on time. And a weather event hundreds of miles away can still decide whether the customer sees us as reliable. That means the courier is effectively one of our production inputs, even though the courier is not on our payroll. The customer's experience does not stop at our loading dock. This also makes shipping a meaningful part of unit economics. A Monarch order form effective in 2023 listed roughly 350 disinfected larvae at $295. A complete megapack was listed at $410. The same dated form listed overnight shipping options ranging from $69 to $135. Those are historical numbers, not current prices, but they illustrate the structure beautifully. When a few hundred larvae can fit into a small package, physical weight is almost irrelevant. The expensive part of the journey is speed, temperature control when needed, reliability, and timing. In other words, the logistics cost is not proportional to the size of the product. It is proportional to the consequences of being late. That is a very different business, and it gets stranger when we consider replacements. If a box of ordinary supplies arrives a day late, the customer may be annoyed. If our living product arrives outside its useful window, we may have to replace it, credit the shipment, or lose the customer's confidence. So one late package can hit us 3 times. First, we lose the value of the original batch. Second, we may pay for another batch and another shipment. Third, we weaken trust with a customer base that may already be small. That third cost is the hardest one to model. It also changes how we think about geography. A customer on the other side of the country is not simply farther away. It may expose us to more connections, more weather systems, more courier handoffs, and a narrower margin for error. We do not have data that lets us assign a universal failure probability to any of that, and we should not pretend we do. But from an owner's perspective, every additional point of failure is a question we have to design around. Do we limit where we promise next-day service? Do we maintain alternative courier options? Do we schedule production around flight cutoffs rather than around laboratory convenience? Do we absorb replacement costs as customer service, or price enough margin into the business to survive them? Those decisions make this feel less like shipping a medical supply and more like running an airline connection for something alive. And it leads us directly to the customer side of the business. Because even perfect logistics are useless if not enough hospitals want the product often enough. At this point, it would be easy to turn this into a medical explainer. We are not going to do that. For our business, the important medical facts are the boundaries of the market. FDA describes medical maggots for debriding specified non-healing necrotic skin and soft tissue wounds. That is enough to understand the commercial constraint. Our addressable customer is not every hospital department, and our product is not for every wound. It sits inside a defined clinical niche. So our sales problem is very different from selling gloves or syringes. A hospital can order enormous quantities of basic consumables because almost every floor uses them. Our product may be needed only when a particular clinician sees a particular case and decides the product fits. That creates concentration risk naturally. We have a real operating example from Caprina, though it is important to keep the geography straight. Caprina's customers are primarily public and private hospitals and clinics in Singapore. In 2025, its 5 largest customers represented 65.7% of total revenue. Its largest customer alone represented 28.3%. Those are not United States industry statistics, but they show what a niche hospital supplier can look like when volume is small. Lose one customer, and the change is not a rounding error. Cuprina also says those hospital and clinic sales are made case by case rather than under long-term written sales agreements, with delivery typically within 1 day of a purchase order and payment typically due within 30 days after treatment. Again, that is its Singapore model, not a rule for American hospitals. But as owners, the lesson travels well. We cannot assume a narrow clinical product gives us predictable subscription-like demand just because the biology is repeatable. Demand may be episodic. The prescription channel creates another gate. Monarch says its medicinal maggots require a doctor's order or prescription. So even if a wound care nurse likes the concept, the commercial process does not become an ordinary retail sale. Then there is reimbursement. Monarch's own U.S. reimbursement guidance points to wound care coding, bundled services, documentation requirements, and payer-specific rules. That does not mean reimbursement is impossible. It means we should not build our business plan around a simple sentence like, "Insurance covers it." There may be coding, there may be documentation, there may be site of care differences, there may be payer policy. And from our side, uncertainty at the provider level can slow adoption even when our product is legally marketable. This is another hidden cost of selling to hospitals. The commercial product is not just the vial. It includes education, ordering clarity, documentation, clinical support within lawful boundaries, and the confidence that the purchasing and care teams understand how the product fits into their workflow. That sounds expensive. It also means customer acquisition has a strange payoff curve. The first order from a hospital may be economically unimpressive. It might represent one patient, one prescription, one shipment, and a mountain of effort around vendor setup, education, ordering, and trust. But the second, third, and 10th orders from that same relationship can matter more because the commercial friction has already been reduced. This is where an owner's view differs from a simple market size view. We do not only care how many potential patients exist, we care how many institutions can become repeat, operationally predictable customers. 1,000 scattered one-time opportunities can be less valuable than a smaller network of institutions that know how to order, know when to order, and trust the product enough to do it again. And there is a working capital wrinkle. In Cuprina's reported Singapore model, product can be delivered within a day of a purchase order, while payment is typically due within 30 days after treatment. That means the supplier can spend on production and logistics before cash arrives. Again, we cannot assume an American hospital will use the same terms. But we should include the possibility in our owner model because a small company selling to institutions can become profitable on paper and still feel cash-starved if receivables grow faster than the bank account. So our sales team is not just chasing revenue, it is chasing demand density, repeat behavior, and payment reliability. Those are very different things. So now, finally, we can ask the question every owner wants to ask at the beginning. How much money can one order make? The frustrating answer is that public current U.S. pricing data for medicinal maggots are thin, and that is exactly why we should resist the temptation to manufacture an impressive margin percentage. We have a useful historical anchor from Monarch's 2023 order form. Roughly 350 disinfected larvae were listed at $295, while a more complete kit was listed at $410. We also know current Monarch pages no longer publish a simple public price in the same way. So if we use the old number, we label it for what it is, a dated reference point, not today's market price. The broader lesson is more interesting than the exact dollar amount anyway. We are not necessarily selling larvae by the pound or by the thousand. We are selling a prepared, controlled, single-use medical product attached to a clinical event. That means packaging, prescription handling, quality control, time-sensitive delivery, and support can matter as much as the physical organism count. There are also different possible pricing structures. Cuprina says that in Singapore it is sold MediFly by single vial and is also offered unlimited vial subscription periods such as weekly or monthly packages. We should not assume that model exists in the United States, but it demonstrates that the revenue model does not have to be one vial, one invoice forever. An operator can potentially think about the customer's treatment pattern, the purchasing relationship, and the predictability of demand when designing commercial terms, subject to the rules of that market. That gives us 3 different revenue questions. First, what is the price of the product itself? Second, who pays for urgent freight and replacement risk? Third, can we create enough repeat demand to make the customer relationship worth the fixed commercial effort around it? The first question is easy to see on an invoice. The second can quietly eat margin. The third determines whether the company can scale. A high price per vial is not useful if each order requires a fresh round of education, documentation, special handling, and unpredictable production scheduling. A slightly lower effective price can be more valuable if the account orders repeatedly and lets us plan the factory. That is why the subscription example from Cuprina is interesting, even though it belongs to another market. It is not the subscription itself that matters. It is the attempt to convert uncertainty into a relationship. This is where many unusual businesses look attractive from the outside. We see a small physical product and a price that seems high relative to raw material. Then we imagine enormous gross margins. But raw material is not the right denominator. The correct question is how many paying orders we can spread the fixed production system across. And we have a real company filing that shows exactly how brutal that distinction can be. Cuprina's public filing gives us something rare in this niche: actual operating numbers. For 2025, the company reported total revenue of 49,894 Singapore dollars, about 38,789 US dollars at the conversion used in its filing. 88.6% of that revenue came from Medifly products. Now compare that with cost of revenue. The company reported 50,539 Singapore dollars, about 39,290 US dollars. At the company level, that produced a gross loss of 645 Singapore dollars, about 501 US dollars, or a gross loss margin of 1.3%. We have to be precise here. This is not a United States medical maggot industry margin. It is not even a pure Medifly product margin, because Cuprina also had another product line. It is one company's reported result. But the filing explains why the example matters. Cuprina says the majority of its cost of revenue is fixed in nature, primarily costs tied to Medifly production staff, production space rent, and depreciation on production equipment. Those costs stayed fairly consistent even as revenue moved around. That is the economic heart of our business. The larva may be biologically cheap. The capacity to make a medical-grade larva is not. We need the room whether we ship 1 order or 10. We need trained staff even if the hospital does not call today. We need quality controls even when the batch is small. We need the equipment before utilization is high. We need regulatory compliance before sales justify it. So fixed cost absorption becomes the real game. Cuprina says the number of patients using Medifly increased from 78 in 2024 to 96 in 2025. Again, that is one operator in its own markets. But combine that small patient count with the fixed cost structure and the risk becomes obvious. The company can be technically capable of making the product and still struggle economically because the facility is waiting for demand. This is why we should not ask, how much does it cost to breed 250 larvae? That question is almost useless. We should ask, how much does it cost to keep a compliant system ready for the moment somebody needs those larvae? That difference is where the strange margin lives. There is an important consequence here for scale. If most of our cost base is fixed, early growth can look terrible, and later growth can look disproportionately better, even if the product price does not change. The first 50 orders have to support the same room, the same quality system, and much of the same expertise that 500 orders might use. That creates a threshold effect. Below a certain utilization level, every new order feels too small to matter. Near the threshold, each new recurring account can suddenly matter a lot. Above the threshold, the bottleneck can move again, from demand to production capacity, staffing, or logistics. We do not have public data that gives us the universal threshold for this industry, but we do not need it to understand the shape of the business. We need enough volume to escape the gravity of our own readiness costs, and it suggests a possible owner strategy. If one living medical product creates a utilization problem, maybe we add another one. Not because it is similar biologically, because it might use the same kind of customer relationship, hospitals that need an unusual living product on demand. That brings us to medicinal leeches. If medical maggots already sound like an improbable hospital product, medicinal leeches make the catalog feel even less like a normal device company. But once again, the regulatory description strips away the mythology. FDA lists medicinal leeches under product code NRN. The device is indicated as an adjunct when venous congestion may delay graft tissue healing, using prolonged, localized bleeding to help relieve that congestion. A 2015 FDA 510(k) summary for Carolina Biological describes the medicinal leech as laboratory-raised. That detail matters for our business story. We are not simply collecting creatures and shipping them to a hospital. The commercial product sits inside a controlled supply chain. The inventory behavior is also different from maggots. BioPharm's current guidance for clinical leeches says they can be maintained in a refrigerator or a cool place and provide storage systems for both short-term and longer-term holding. We should not turn one supplier's maintenance guidance into a universal rule for every leech product, but it creates a useful contrast. Monarch's medicinal maggots are a just-in-time problem measured in hours after arrival. Leeches can behave more like living inventory that requires maintenance. That changes the cost structure. With maggots, our enemy is time to use. With leeches, part of our cost can become the ability to store, monitor, maintain, and rapidly dispatch live inventory. There is also current public price information from Leeches USA. The company advertises Hirudo Medicinalis at $20.15 each for orders of 7 to 99 and $18.15 each for 100 or more. The company says regular delivery has a 7-leech minimum, shipping is added, orders are non-cancelable and non-refundable, and leeches are not returnable. Those are one supplier's advertised prices and terms. They are not a universal hospital acquisition price, but they show us something about the commercial unit. A hospital may need only a relatively small number of animals, while our cost base includes maintaining the capability to supply them correctly. Leeches USA also advertises emergency delivery 365 days a year, with after-hours orders shipped in pre-packed units of 20. That is a clue about what the customer is really paying for, not just a leech. Availability. If a surgical team needs a living product outside normal business hours, the supplier's ability to answer the phone, maintain inventory, package it, and move it immediately becomes part of the value proposition. From an owner perspective, this is almost the mirror image of the maggot problem. With maggots, we have to prevent finished inventory from aging past its useful window. With leeches, we may have to accept the cost of maintaining living inventory precisely so we can be useful when demand is unpredictable. One product punishes us for producing too early. The other can punish us for not holding enough readiness. That difference affects staffing too. If we advertise emergency availability, the service promise can extend beyond the organism and into our people. Somebody has to receive the request. Somebody has to prepare the shipment. Somebody has to know the product is in condition to ship. The commercial value may rise because the customer is urgent, but so can the operational burden. This gives us a broader view of the company we are building. The maggot side looks like highly perishable, made-to-order manufacturing. The leech side can look more like maintained live inventory plus urgent fulfillment. Those two products could diversify our operating model. They can also make the company more complicated. We now have 2 biological systems, 2 product categories, 2 inventory behaviors, and potentially 2 sets of failure modes. Diversification is useful only if the shared commercial infrastructure is worth more than the added operational complexity. That is an owner question, not a zoology question. But even 2 products do not remove the biggest danger. A niche business can have 2 products and still be dangerously concentrated. When people talk about concentration risk, they usually imagine one giant customer. In our business, concentration can appear almost everywhere. Customers, suppliers, know-how, shipping, clinical demand, regulatory permission. Start with customers. In Cuprina's 2025 results, the 5 largest customers represented almost 2/3 of total revenue. The largest customer represented more than a quarter. Again, those are Cuprina's numbers in its markets, not a U.S. average. But if our own customer list ever looked like that, one purchasing decision could change our year. Now look at suppliers. Cuprina breeds its own maggots internally, yet its 5 largest suppliers still represented 74.8% of its 2025 cost of sales. Why? Because even when we manufacture the living component ourselves, we still depend on vials, consumables, equipment, packaging, logistics, and other inputs. The organism does not make us vertically independent. Then there is know-how. Cuprina says its maggot product is not protected by patents and that the business relies on trade secrets and process knowledge. That can be a moat, but it can also create key person risk. If the process lives partly in specialized human expertise, losing the right technical people can be more disruptive than losing a generic production worker. And finally, there is shipping concentration. We may use multiple courier services where possible, but the basic dependency remains. A living product with a narrow delivery window is exposed to systems outside our control. That is why a tiny company can feel strangely infrastructure-heavy. We need a medical quality system. We need biological production. We need specialized labor. We need compliant packaging. We need rapid logistics. We need clinical relationships. And we need all of that to support a market that may be small enough for a few hospitals to dominate our revenue. This is the exact opposite of a software startup. Software can sometimes add a new customer at almost no incremental production cost. Our company may have to preserve physical readiness even when no new customer appears. There is also a timing mismatch that can make concentration feel worse. Suppose one large account becomes a major share of our orders. We respond rationally by staffing around it, scheduling production around it, and buying materials around it. Then the account slows down. The revenue can disappear faster than the cost structure adjusts. Our room is still leased. Our team still exists. Our colony still needs management. Our quality system still has to function. That is why concentration risk is not merely the chance of losing revenue. It is the chance that our cost structure becomes stranded when revenue leaves. The same thing can happen on the supplier side. A specialized vial, packaging component, or service can look like a minor line item until it becomes unavailable. Then the issue is not what it costs. The issue is whether we can release product at all. We do not have evidence that any specific component has caused that kind of disruption in this market, so we should not invent one. But Cuprina's supplier concentration tells us that the dependency is worth taking seriously. A robust owner would want alternatives where alternatives are possible, documentation around qualified suppliers, and enough working capital to absorb the inefficiency that redundancy can create. Redundancy looks wasteful right up until the day it becomes the reason we can ship. So now we can finally build the 2 owner scenarios. Not as forecasts, not as industry averages, as thought experiments that show how the same business can look completely different depending on utilization. Assume 4 billed maggot vial equivalent orders per week for 50 weeks, valued only for illustration at Monarch's historical 2023 $295 per vial public anchor. 30 leech emergency packs per year, each modeled as 20 leeches valued at the current Leeches USA lower volume advertised price of $20.15 per leech. No shipping revenue or shipping cost is included because supplier/customer arrangements vary. Assume annual fixed operating costs of $260,000 for staff, facility, quality/compliance, insurance, software, equipment maintenance, and other readiness costs. That $260,000 is purely hypothetical. Add the verified FY 2026 establishment registration fee of $11,423 and, for a first-year illustration, the standard 510K fee of $26,067. Assume variable consumables, packaging, biological waste/replacement exposure, and other order-linked costs equal 20% of modeled product revenue. This 20% is hypothetical. Greater than, suppose we do everything responsibly. We build the quality system. We maintain a small, compliant production operation. We have trained people. We keep the biological colony healthy. We secure the regulatory path appropriate to our product. And then, the phones simply do not ring often enough. This is the nightmare version of the business because nothing has to fail dramatically. The science can work. The product can be viable. The facility can be ready. The problem can be boring. Not enough utilization. So let us force the problem into numbers. Our model gives us 4 maggot vial equivalent orders per week for 50 weeks. Using only the old 2023 price as an illustrative anchor, that produces about $59,000 of modeled annual maggot product revenue. Then we add 30 emergency leech packs during the year. At 20 leeches per pack and a little over $20 per leech, that contributes about $12,090 in modeled product revenue. Together, our 2 living product lines produce roughly $71,090. That is the top line in the model. Now we apply the costs we deliberately assumed. 20% of product revenue for variable consumables, packaging, replacement exposure, and other order-linked costs is about $14,218. Our hypothetical fixed operating base is $260,000. Then the verified fiscal year establishment fee adds $11,423. And because we are modeling a first year, the standard 510K user fee adds another $26,067. Put it together, and our illustrative first-year cost burden lands at roughly $311,708, against about $71,000 of product revenue. The gap is around $240,000. Again, that is not an industry loss estimate. It is the result of assumptions we chose openly. But the direction is what matters. We cannot rescue this business by negotiating a cheaper fly colony. Even if the larvae themselves were free, the model would still be in trouble. The loss comes from readiness without enough demand. The room exists whether we ship 4 orders this week or none. The people exist whether the hospital calls today or next month. The quality system does not become optional because sales are slow. And if our demand is too inconsistent, we may also lose product or labor efficiency around batches that do not line up cleanly with orders. Cuprina's filing gives us the real-world version of this pressure. It says most cost of revenue is fixed, especially production staff, production space rent, and equipment depreciation. In 2025, the company reported a small company-level gross loss, even though most of its revenue came from MediFly. That is the cautionary case. A tiny biological input does not create a tiny cost base. Now look back at our startup capital illustration. We modeled more than $500,000 of capital and runway just to make the first year survivable. Scenario 1 shows why. A business can burn through runway even while doing every technical thing correctly. And because the customers are concentrated, the road out of the loss can be fragile. If we only have a handful of hospital accounts, one hospital changing protocol, one clinician leaving, or one purchasing relationship going quiet can push utilization backward. We do not need a catastrophic recall to lose money. We can lose money simply by being ready for a demand level that never arrives. That is scenario 1, a medically credible company with commercially underused infrastructure. The organisms are alive, the business is not. So what changes in scenario 2? Not the price of a fly egg, the utilization of everything around it. Now imagine we have solved the customer problem better. We have a group of hospital and clinic relationships that order often enough for us to plan production around real demand instead of hope. We still do not know tomorrow perfectly, but the order pattern is dense enough that the insectary, quality staff, and facility are no longer spending most of their time waiting. The same fixed system now supports more billable product. So we run the second model. 24 maggot vial equivalent orders per week for 50 weeks gives us 1,200 annual orders. At the same deliberately dated $295 historical anchor, that is about $354,000 of modeled maggot product revenue. Then we add 200 leech emergency packs through the year. At 20 leeches per pack and the current supplier list price anchor, that contributes roughly $80,600. Our modeled product revenue is now about $434,600. The biological products did not become dramatically more expensive. The facility simply got used more often. Now apply the cost assumptions. 12% of product revenue for variable order-linked costs is about $52,152. Our larger fixed operating base is $300,000. The annual establishment registration fee adds $11,423. Total modeled cost is roughly $363,575. That leaves about $71,025 of modeled headroom before financing, taxes, owner compensation beyond what is already assumed, unexpected legal expense, uncompensated shipping, or any other cost we failed to model. That is not a claim that this business earns a 16% margin. It is not a prediction at all. It is a demonstration of operating leverage. With weak utilization, the exact same type of company can lose hundreds of thousands of dollars in our illustration. With denser demand, the fixed system starts to earn its keep. And notice what did not drive the improvement. We did not discover a cheaper species of fly. We did not double the price. We did not pretend hospitals suddenly became a mass market. We changed utilization, scheduling, and the ability to spread readiness costs across more orders. That is the business. Then we improve the logistics side. We tighten order cutoffs. We build redundancy into our shipping procedures where possible. We become better at matching production to the clinical schedule. We learn which customer workflows create avoidable delays. We reduce the number of shipments that have to be replaced because timing failed. Again, we are not assigning a sourced failure rate. We are describing the lever. Every avoided replacement protects the value of the first batch and the cost of the second. Then we look at the leech side of the catalog. The interesting revenue opportunity is not necessarily the animal's unit price. It is the service around urgent availability. If we can maintain living inventory correctly and supply it when the customer needs it, our company becomes useful in two different ways. For maggots, we are good at made-to-order biological production. For leeches, we may be good at maintained live inventory and fast response. That does not guarantee profit. It does give our fixed commercial infrastructure more reasons to exist. Our hospital relationships can potentially support more than one niche product. Our ordering support can serve more than one use case. Our live logistics expertise can become broader. Our reputation for reliable biological handling becomes an asset that is harder to copy than the organism itself. Caprina's own pricing history in Singapore gives us another idea. It is used both per vial sales and subscription periods for maggot products. That does not mean we can or should copy the model in America, but it reveals the strategic question an owner should ask. Can we convert episodic demand into a commercial relationship that is more predictable for both sides? If the answer is no, we remain a reactive vendor. If the answer is yes, some part of our demand risk may become easier to plan around. And there is one more uncomfortable lesson in the second model. Even after we increased annual product revenue to more than $400,000, our illustrative headroom was only about $70,000 before several categories we deliberately left out. So a stronger operator still cannot become casual. One bad customer loss, one prolonged logistics problem, one regulatory expense, or one period of lower utilization can erase the cushion quickly. That is what makes this business interesting. Scale helps, but scale does not make the company normal. It makes the same strange system less fragile. That is the stronger scenario. Not a magical high-margin insect farm, a disciplined, specialist supplier with enough demand density to make its regulated capacity useful. And now the business formula becomes much clearer. Go back to the first vial. Roughly 250 living larvae. If we only looked at the contents, we would misunderstand almost everything about the company. The larvae are not where most of the difficulty sits. The difficulty sits in the chain around them. A controlled environment, a repeatable production process, disinfection and quality control, documentation, a regulatory path, a quality management system, prescription handling, packaging that keeps a living product usable in transit, a courier schedule that cannot casually slip, a hospital relationship strong enough that the order actually arrives, and enough order volume to spread fixed costs across something larger than a handful of cases. Cuprina says its Medifly product had no patent protection and relied on trade secrets and manufacturing know-how. That sounds like a weakness until we see the full business. Because the organism is not the moat, the system can be. Monarch's old FDA file shows late delivery was once its most common complaint. Cuprina's filing shows how fixed production costs can overwhelm low revenue. Its customer numbers show how quickly a few hospitals can dominate a small supplier. Its process description shows why the business needs more than a cage and a shipping label. Put those pieces together, and the company starts to look completely different. It is part biological manufacturer, part regulated device company, part live inventory manager, part time-critical logistics operation, and part relationship business selling into a narrow clinical market. The strange part is not that a hospital can buy maggots or leeches. The strange part is how much invisible infrastructure has to exist so that buying them does not feel strange to the hospital at all. If we owned this company, that would be our real product. Not the larva, not the leech. Reliability. The confidence that something alive will arrive controlled, documented, viable, and exactly when it is needed. Our first scenario failed because readiness existed without enough demand. Our second scenario improved because the same readiness was used more often. That gives us the simplest owner formula in the entire episode. We are not trying to make the cheapest organism. We are trying to make expensive readiness look cheap on a per-order basis. We do that by controlling the biology, earning the regulatory right to sell, building hospital trust, keeping logistics reliable, and finding enough repeat demand that the fixed system does not sit idle. The larvae create the click. The leeches make the catalog stranger. But the actual business is much less exotic and much harder. It is operations, and that is where the margin has to come from, if there is a margin at all.